Good morning, everybody, and welcome. Today, our speaker is Dr. Nicky Oosthuizen. Dr. Oosthuizen is a chemical pathologist in private practice with PathCare Laboratory since 2016. She qualified as a specialist in 2000 and held a joint appointment as consultant and lecturer in the National Health Laboratory Service and the University of Pretoria for 16 years. 5 of them as acting head of Department of Chemical Pathology. She has extensive experience in general medical biochemistry and as of January 2025 has focused her practice on autoimmune diagnostics. Thank you.
Thank you very much for the welcome and the introduction. Okay, so my talk today is going to focus on ANA and ENA testing in terms of laboratory diagnosis. I'm not going to do, it's quite a big topic. It's going to be sort of more of an overview, of the whole topic. All right, so if we speak about ANA, it's referring to anti-nuclear antibodies, but as we all know, it's not only nuclear antibodies that are detected. There's also other antibodies in the cell that we pick up when we do our ANA test. So nowadays, the term that they're suggesting should be used is anti-cell antibodies. So the method that we're using, indirect immunofluorescence, is the gold standard method. And then if you look here at this diagram over here, so basically you have a slide, and on the slide, you've got human epithelial 2 cells that have been fixed there. And in our lab, we also use primate liver. So on the same slide, you'll have the HEP2 cell as well as the primate liver. The idea is then to take the patient's sample, you add it to the slide. If there are autoantibodies present in the patient's serum, it will bind to the components of the cell that are relevant for the autoimmune disease that the patient has. And then you will do a wash step. Okay, and then next step is then to add a secondary antibody that's fluorescein labeled. And that antibody then attaches to the autoantibodies that have become linked to the slide. We wash it again, and then we visualize the fluorescence using a fluorescence microscope. Okay, so this picture is a little bit small, but what you can see here, this is the cell. The dark blue part is the nucleus, and that's the cytoplasm. There's some tiny antibodies that have, become affixed over there, and then you have your secondary antibody. The schematic at the bottom, what this is showing is that different patterns that we can then identify. So this is your interface cell. So we look at 2 cells, the interface cell and the metaphase cell. That's very important for us to figure out what pattern it is. We'll go through these patterns a bit later, but you'll say, just for example, the nuclear homogeneous pattern, the interface cell looks like that. There's the nucleus with the fluorescence. And then if you look at the metaphase cell, you'll see there aligned along the metaphase plate, you can see for example, in this case, it might be double-stranded DNA that's been identified. All right, so then nowadays we are using an automated slide maker with a digital microscope, and it's got pattern recognition software. Although it's not fantastic, one always thinks that AI is going to take over your job, but it just classifies in very broad categories. So it will say nuclear homogeneous, it will say speckled, but it doesn't differentiate between fine speckled and coarse speckled. And then it will say cytoplasmic, it's got nucleolus, it's more your broad categories of patterns. So we don't just take the classifier's interpretation. We look ourselves and then decide what we think it should be. It also gives an estimate of the theta. So in the same way, if we don't agree with the estimate that it's giving, we are looking at the intensity of the images. We decide what the theta is. It's usually not a big difference, maybe within 1 theta either way. Okay, then, so that's one way of doing it. The classical way of actually doing it is endpoint titration. So we don't do endpoint titration for every single patient. Sometimes the pattern is easy to see, but if the fluorescence intensity is very great, so you can see it's a very strong specimen, and you think there might be patterns hiding behind, then we do further titers. So the beginning titer is 1 in 80. That's your screening titer. Then if you want to titer further, you can go 160, 320, 641 to 80. You can do further titers too in order to visualize the whatever has bound there better. And the other thing that you might also want to do further titers is, for example, if your results don't agree, especially if you have maybe previous results, and let's say it was a very strong, nucleolar pattern, and now it's saying negative, and you can't see much, then it could be a question of antigen excess. So if we look at this slide over here, so that's where the signal is too strong, and the antibodies, they can't, there's too much antigen, so it doesn't form a nice stable lattice, because you can see just about every antibody has got the antigen bound to it. The ideal situation would be this zone of equivalence, where you have just the right amount of antigen and the right amount of antibody. Then it forms a stable lattice, so when you do your wash step, it stays on the slide. With antigen excess, when you do your wash step, it can be washed away, and then when you visualize it on the microscope, it looks negative. Okay, so all right, so that's that. Then in terms of the ANA patterns, we are using the international consensus on ANA patterns. So this is an international group which has decided what the patterns are going to be. You can see that there are 31 of them. In terms of the nuclear patterns, we've got 17, 1 to 14, and then 29, 30, and 31. And then we've got this 9 cytoplasmic patterns, and then there's 5 mitotic patterns. I just want to bring your attention to, you'll see a thing saying, yeah, metaphase plate is stained. That is something that's very important when we look at the slides to help us decide what the pattern is. So certain patterns have got a positive metaphase plate. So that's in your metaphase cell where your condensed chromosome is aligned. If it's positive, then it sort of brings it down to a couple of patterns. You can see AC1, AC2, AC30. AC3 is also one, that centromere pattern. It also gives you a positive metaphase. Sometimes your nucleolar patterns, 2 of them, can also look positive. And then is it 14? Centromere, protein F. They can also have a positive metaphase, and then AC28 can have a positive metaphase. All right, we're going to go into in more detail, but this is the overview of the classification that we follow. All right, so as I mentioned, the screening titer is 1 in 80. So if we can see fluorescence at 1 in 80, then we call it low positive. But you can see that any a positive ANA doesn't always mean autoimmune disease, because you can have positivity in healthy subjects. Obviously, at lower titers, a greater percentage of healthy subjects can have fluorescence. And then as we move up with the titers, it becomes less likely. And at a titer of greater than 1 in 320, then it's more likely that there is a systemic autoimmune rheumatic disease present. That's more for your nuclear patterns and your mitotic patterns. For your cytoplasmic patterns, sometimes even a lowish titer could mean that there is autoimmune disease. All right, then in terms of the patterns, certain patterns are more associated with autoimmune disease than others. So your nuclear homogeneous, centromere, coarse speckled, these are more suggestive. And then you also do get 2 patterns that actually AC30 has only really been identified or included in the ICAP classification recently. So that's AC2, dense fine speckled, and AC30. Those are actually patterns that you might find in healthy individuals without a systemic autoimmune disease. All right, then in terms of the challenges that we experience with the ANA, sometimes SSA, especially the row 52, can be poorly detected. So the way that you might find this is that your ANA is negative. When you do your ENA screen, it's positive, and when you do a breakdown, you find that the SSA is elevated. So that means that it might be that it's row 52, and that's why it hasn't been clearly visualized on your ANA. Okay. The other thing is that Dr. Myburg also mentioned last week with your inflammatory autoimmune myopathies, sometimes the HEP2 will be negative. Also because the cytoplasmic patterns are quite difficult. They're quite difficult to distinguish sometimes between, for example, an AC19 and an AC21. We'll get to what that means. So one is actually more, you see it more with autoimmune inflammatory myopathy. The other you see more with liver disease. So it's a bit tricky, your cytoplasmic patterns. The other thing is that we often see non-specific cytoplasmic fluorescence, especially as well if your nuclear pattern is very strong. Then it's almost like a kind of a spillover from the very intense nuclear immunofluorescence. Okay, this is a site that you can go and look on. So it's got all of your AC patterns are there. There's a small description of it, and then it tells you what the clinical associations are. So you can go look, you don't have to register, you can just go there and have a look at it if you want to know more. Then in terms of what we do next, so there's two legs to the investigation. The one is your ANA, the other is your ENA. Okay, strictly speaking, I suppose we should be calling these ACA and ECA. The screen that we use in our lab includes 14 antigens, or 14, it detects 14 autoantibodies. Okay, so we are using enzyme immunoassay for the ENA part of the test. All right, so there's the whole list of them. You can see double-stranded DNA, SSA. The SSA will actually detect both types of SSA, row 52 and row 60. Smith, U1, RNP, you can see all of them there. And then PM Scler is also both the 75 and the 100. All right, so that's what the whole ENA screen includes. What it does not include is, for example, histone. So if we see a nuclear homogeneous pattern where it could be due to histone, we have to measure histone separately. So for all, when we see AC1 pattern, we do a histone. Okay, if we think it's an AC2 pattern, we do a DFS 70. If we think it's a reticular pattern, we do M2. And then you also see their double-stranded DNA nucleosome. I'm going to get back to that a bit later. All right, so how it basically works, if the ANA is negative and your ENA is equivocal, we will suggest to the clinician, on our report, we'll say we suggest that you do double-stranded DNA and SSA. If the ANA is negative with the positive ENA, then we actually measure those two. Those are the ones that are most likely to actually be positive. All right, then I'm going to say a little bit more about Crithidia later on the next slide. And then if your ANA is positive and you've got a positive ENA screen, we do a breakdown according to the pattern. But you can understand that we can't measure all 14. That is going to be very expensive. It costs about 250 Rand at least for each of those. So you can't do 14 of them. So you have to do the ones that are most likely going to be picked up. So, for example, for AC1, which is your nuclear homogeneous, we measure histone, as I mentioned. And if the ENA is positive, we do what we call an SLE panel. So I'll get to what that includes, but it's going to be the antibodies that are associated with SLE. The same for an AC2 and AC29. I'll just tell you why just now. And then AC13 is a pattern that's also associated with SLE. For all of those ones, we do like an SLE panel. If we see nuclear fine speckled, we do a panel that includes antibodies that you see with that. If we see a coarse speckled, we do 2 extra ones. Okay, and then so these are the more, that's centromere, we'll look at it just now. And then we've got a nucleolar panel, 4, 8, 9, 10, that's your nucleolar patterns. And then for your cytoplasmic patterns, 19, you do certain ones, and then for 20, you add JO1, because that's what you expect to find with the AC20. Okay, we're not gonna, this is just for completeness, so don't worry about it. It's okay. What I want to show on this slide is that although often in an interpretive comment that you see on your report, we will say, oh, a nuclear homogeneous pattern was identified associated with SLE, drug-induced lupus, rheumatoid arthritis, autoimmune hepatitis. These things are not like mutually exclusive. So you can see in an SLE, you will find nuclear homogeneous, but you can also find other patterns. Okay, so you can see, for example, over here, this one is AC4, nuclear fine speckled. Okay, rheumatoid arthritis, many of, let's say about half of them might be ANA negative, but quite a lot of them are AC1 as well, and the others AC4. In fact, AC4 is kind of it's a very common pattern that you see. All right, so the idea of this slide was just to show you that these things are not like in silos. It's not, if you've got SLE, it must be AC1. It can actually be AC1, it can be AC4, it can be a nucleolar pattern, it can even be cytoplasmic patterns. All right, so here we come to nuclear homogeneous pattern. So what you can see is this is the nucleus. It's got this kind of smooth fluorescence. And this over here is now supposed to be the metaphase. It's a bit of a fat one, so it's not typical, but it's showing you that it's a metaphase cell. So if I would draw the outline of the cell, it would be like, you know, around there. And then this is along the chromatin plate, it's positive. And as I mentioned, so we look at 2 things. We've got HEP2 cells and the primate liver. The primate liver helps us because there are certain features on the primate liver which would be in favor of a homogeneous. So you can see it's quite large and bright, right? Okay, so as I said, what we do, if we see this pattern and the ENA is positive, we do a breakdown. So the breakdown includes double-stranded DNA, SSA, SSB, Scler70, Smith, U1 RNP, and ribosomal P. Now, ribosomal P, strictly speaking, that's in the cytoplasm, but we don't want to miss it. Okay, so it's included because it's part of your SLE panel. Okay, and then you can see histone antibodies will also measure them. But if they can be high, and if they are high, it could be just in idiopathic SLE, or it can indicate drug-induced SLE. And there are certain drugs which are associated with drug-induced lupus. So it's your antiarrhythmics, procainamide, it's INH, certain anti-epileptic medication, as well as things like your TNF-alpha inhibitors can also give you a positive histone. All right. If our double-stranded DNA is low, okay, so that's not only for the AC1 pattern, it's lowish and you're not really sure if it means anything. Then we can do a further test that we call Pretoria lucilia immunofluorescence. So that is it's a little organelle, a little microorganism that's got an organelle called the kinetoplast. And this kinetoplast has got double-stranded DNA in it. And so what we do is, it's almost similar to the slide, we add the patient sample. So if there is double-stranded DNA in the patient sample, that is your high avidity kind of double-stranded DNA, the kind that you would associate with SLE and possibly with renal complications of SLE, then you will find a positive result. So it's a way of kind of saying, all right, it's likely that the double-stranded DNA that we're observing is actually related to SLE. Okay. Sometimes when your double-stranded is lowish and the pattern is not an AC1 and you're not really sure, we can do the Clift as well. In that case, if you find then So in other words, you've measured your double-stranded DNA elevated, but when you do your clift, it's negative. So the interpretation of that can be either it's a false positive double-stranded DNA, or it's a non-SLE related double-stranded, like, for example, that's been induced by a viral infection or due to medication. And the other option could be that it's a very early or an inactive SLE. All right, so if we find all of these things negative, the other thing that's very important to look at is your RF and your CCP. Because we find a very high percentage of patients with rheumatoid who've got an AC1 pattern. So then you have your AC1 pattern, your ENA screen is negative, your histone is negative, your RF is elevated, we'll say most likely the pattern is due to rheumatoid. Okay. Sometimes when we do all of these tests, we find nothing, but the theta is very high. Now it's like we haven't found the reason for the pattern. So what we would suggest then is to do your double-stranded DNA nucleosomal. So that's double-stranded DNA that's coupled to nucleosomes. And if that's positive, then that is also quite specific for SLE, but it's not diagnostic. So you still need to look at your diagnostic criteria. Okay, so we're not going to go through all of this. All I want to show here or to point out is that the entry criterion is that there must be a positive ANA greater than 1 in 80. And then the other thing that I want to point out here is this sentence over here, the double-stranded DNA assay must have a specificity of at least 90% for SLE. And if it is an assay like that, which most assays are, then you can assign 6 points to it for your scoring system. Your nucleosomal DNA. So let's say you have a patient, you have an AC1 pattern, the theta is high, it's 640, but now your double-stranded is negative. Okay, then you can do your nucleosomal, and then you can use that nucleosomal in the scoring criteria as well. Okay, then the next two patterns are ones that are actually quite important because these are ones that if you don't diagnose them correctly, you will be saying that a patient has an autoimmune disease when they might not have it. Okay, so you can see that this is the metaphase cell over here. It does have a positive chromatin. The metaphase plate is positive, but the character of the plate is different from this is a homogeneous one. Nuclear homogeneous over there. It's more solid, and they describe it as having a hyaline appearance. This one is more speckly, and you can also see that you don't have that lovely smooth, the smooth look that we had with a homogeneous. It's all speckly, and there's lots of them. They're all distributed throughout. Okay, so that's what we call, when we see this, we say, we think it could be an AC2. So the first thing we measure is your DFS 70. Then it's fine speckled 70. If that is high, we then look at the ENA. If the ENA screen is negative and there's no other obvious or common ENA detected, so there's no rheumatoid, there's no histone, then you would say most likely this patient does not have an autoimmune disease. All right, then there's a bit of a variation. This is the one that's been recently included. So this is the one that's called nuclear fine speckled with mitotic plate. It looks similar, as you can see, except that your interface cell is not as speckly. And what happens when we look at this one, when we measure the DFS 70, it's negative. Okay, so it's a bit of a tricky one. All right, so then we do have to go and make sure there aren't any other ENAs, because this pattern might arise due to the combination of nuclear antigens, like the ones that you associate with SLE. So you must just go then look at them, check your ENA. If your ENA is negative, your histone is negative. What we do in our lab, we also make sure that the nucleosomal DNA is negative. Then we'll say, oh, it's an AC30. The clinical significance of it is not 100% sure. It's not as benign as an AC2. It's somewhere in between. They could have something, but we couldn't actually detect it. All right, the next one is called AC29 or topoisomerase 1. The other name for it is FLUR70. So you can see there's two different forms of them. I'm not going to go into big detail, but once again, your metaphase plate is positive, and then you have these nucleoli that you can see in the interface cell. If we see this, then and our ENA screen is positive, we do a panel 1, what we call panel 1. It includes scler70 because you want to see if the pattern is due to scler70. If you find scler70 to be negative in that situation, then you will say, oh no, this is not a scler70, this is not AC29, this is a mixed pattern. It's a homogeneous nuclear pattern plus a nucleolar pattern. So it can be quite a tricky business. Okay. Right. Then the next one is nuclear centromere, and this is one of the easiest ones to identify in your slides. So you can see it's got about 45 to 60 very bright speckles in your interface cell, and then your positive metaphase plate has got a zigzag appearance. So this we find with CREST syndrome, as well as with PBC and PBC systemic sclerosis and PBC Sjogren's overlaps, as well as a small subset of patients with SLE and even in rheumatoid arthritis. So they tend to identify different clinical subsets of patients if you see these patterns. All right, so what we're actually identifying here is centromere protein, and the one that's included in our panel is centromere protein B. In our lab, even if the ENA, actually we do it even if the ENA is negative, because we have realized that the ENA screen is not very sensitive to this antibody. So we measure it anyway. Okay. If you don't, let's say you've got quite a strong pattern like this and you don't detect it, okay, then it could mean that it's due to another one, centromere protein A. The only way to diagnose this or to detect it is on a systemic sclerosis plot. Although clinically it might not be relevant to actually do that if you have your clinical features. Okay, this slide is just showing you a question of centromere plus a mitochondrial pattern, reticular mitochondrial. So you can see that you've got your speckles from your centromere, and then you've got your reticular cytoplasmic fluorescence, which you find with your AC21. So that one is suggesting then a PBC overlap. Okay, the next one is then your nuclear fine speckled pattern. As I mentioned, it's a very common pattern, even in patients with non-autoimmune disease. But the typical ones in terms of autoimmune disease that it's associated with is Sjogren's, SLE, systemic sclerosis, and then your autoimmune inflammatory myopathies, as well as systemic sclerosis overlaps. The antibodies that we detect with this is SSA, SSB, and MEAT2. Remember, MEAT2 is a marker for dermatomyositis. And then there's Q, TIF1 gamma, and TIF1 beta. So these ones, the last three, are not included in the ENA screen. So you'll see the pattern, but when you do your ENA, it's not positive. So that means in that case, you will have to go on to do a myositis plot in order to detect those. We've got some clues sometimes that we can say, oh, it could be a coup. This is a picture where so you've got your fine speckled pattern. Typical of speckled patterns is that the metaphase is negative. You can see it's not positive. There's a hollowness at the plate. The plate is not solid. And then if you look at your primate liver slide, it's got this, what they call popcorn appearance. So we see this on the ANA. Our ENA is most likely, it could be positive because of SSA, but it's not going to detect the coup. So then if we see this appearance, we will suggest that you do a myositis plot. The one on the top here is just a new one that they've included in the classification. It's called myriad discrete speckled, and it actually picks up row 60. So you can see it is fine speckled, but they're very bright. There's many of them, and they're very bright. So it's just why you might want to know which is because this is more associated with SLE and Sjogren's than a row 52. Okay. The next one is nuclear core speckled. And as I mentioned, the nuclear core speckled is not, it's usually associated with an autoimmune disease. And you'll see quite importantly, it's one of the ones that we find very often with SLE. Okay. The other one that it's associated with is mixed connective tissue disease. All right, so these are the antigens that it's picking up. Smith, so that's obviously why you would find it with SLE. And the other one is U1 RNP. So what we will do here is we'll see this core speckled pattern. You can see on the primate liver, it's quite prominent. It's almost looks like a homogeneous pattern on the liver. So this gives us a clue that it's most likely a core speckled, because it can be difficult to distinguish between fine and core speckled sometimes. All right, so what we would do then, we measure we do the ENA screen, and then we do the breakdown. Okay, so you can see actually the AC4 and the AC5, the beginning of it's the same, but if we think it's core speckled, we add SM and U1 RNP. So in terms of if you have a patient, U1 RNP is actually sort of the hallmark of mixed connective tissue disease, but you can also find it in SLE, which means that if you look at your ENA breakdown and you have U1 RNP high together with high double-stranded or Smith, then you would say it's likely SLE, not mixed connective tissue disease. Obviously, clinically, this can be difficult because mixed connective tissue disease does include SLE-like features. Do the breakdown and you find only U1 RNP on its own, then you'd say more likely mixed connective tissue disease. I'm not going, those are the criteria, you can go and have a look at them. This is a patient, okay, so you can see a core speckle together with a cytoplasmic pattern. And if we look at that's our ENA screen, it's very high. Most of it's, or a lot of it, there's a lot of double-stranded DNA, there's Smith, and there's RNP. In our lab, we call it RNP1, we'll go in other places, U1 RNP. So I'm kind of used to calling it RNP1. Anyway, so what you can see is that it's very high, but this is not it's likely not a mixed connective tissue disease because of the very high Smith and the double-stranded. And then the ribosomal P antibodies, which you can see here, those are the ones that are responsible for the cytoplasmic pattern. And that's a very important marker for neuropsychiatric SLE. So if RiboP is there, then that fits with any kind of, if it's a neurological presentation of SLE. And then this is just showing obviously your low complement that you also expect with SLE. Right, in terms of our nucleolar patterns, there's 3 of them, but on the slides that we are using, it can be difficult to distinguish between the 3. Okay, so when we see a nucleolar pattern and our ENA is positive, then we do a breakdown which includes PM scler 70, fibrillary, and RNA polymerase 3. Okay, and we check which one is positive. Sometimes when you do your ANA, you see a strong nucleolar pattern, but your ENA is negative. You can find that, for example, with if it's due to a NOR90. NOR90 is not included in the ENA screen. So you will then have a likely an AC10, a nucleolar punctate pattern, together with a high screen, with a normal screen or low screen. So that means you must look for NOR90. The only way that we can detect this, it's not included in our ENA breakdown either. We have to do a systemic sclerosis plot. Okay, so you know the diagnostic criteria. Over here, I'm just showing you what we have on our systemic sclerosis plot. So you can see scler 70, centromere A, that would be the one where you've got a centromere pattern, but your centromere B is negative. And then you can see NOR90, so that's more with your punctate pattern. Fibrillary is there, you've got your PM sclers, and then you've got some of your things which you might find with overlap, like your KU. Okay. Right, so that's the systemic sclerosis plot. Yeah, this is just an overview, of your cytoplasmic patterns. Okay, so not going to go through all of them. The ones that we'll discuss is AC15. So that's the one that you see with smooth muscle, anti-smooth muscle antibodies that you find with autoimmune hepatitis and some other liver diseases. And the other one, AC21. These ones, 16, 17, 18, okay, 19 and 20 are the ones with myositis. Some of these other ones, you're only really going to sort of do a small breakdown because you find them, you can see you find them with all kinds of diseases. So what we normally would do is at least, if our ENA is positive, then we do at least an SSA and a double-stranded. All right, so this is your AC15, and as I've mentioned, it's you find it in autoimmune hepatitis, but also with quite a few other diseases. We don't have an ELISA test or an enzyme immunotest for this. So here we actually have to look for the smooth muscle on tissue. Okay, so you can see it looks like this on the Hep2, and then on the primate liver, it's got this thing which they call chicken's feet. It's got this chicken's feet pattern, and you would say, oh, it looks like smooth muscles. If you really think that it could be autoimmune hepatitis type 1, you can do a more specific test, which is for vascular smooth muscle 47. So this one is much more specific for autoimmune hepatitis, okay? Because you can actually get positive smooth muscles in lots of other conditions. And then cytoplasmic reticular, this is your AC21 pattern, the one that we see with PBC, okay? So you'll see it's a reticular kind of fluorescence, like a web-like fluorescence of the cytoplasm. And then there are other patterns that are also associated with PBC. So you can see them, we've mentioned AC3 already, but you can also find it with AC6 multiple nucleotides and then with nuclear membrane patterns. So sometimes you'll see a combination of these patterns. And if you see a combination, it's very suggestive of PBC, okay? In terms of the antibodies that are causing AC6 and AC12, SP100 and GP210, you can find them on the liver blot. Okay, so you'll see this is the liver blot. All right. Okay, then the next one is your cytoplasmic patterns. There's two of them. One is called dense fine. So you can see sometimes they say this is like quite a dense fluorescence, more like a cloud, looks like a cloud sort of thing. Whereas your fine speckle has got little dots all over the place. So the bottom one with the dots is more indicative of JO1. So that's one, obviously one kind of autoimmune inflammatory myopathy. And then the other one, you'll find more with they're all part of autoimmune inflammatory myopathy or antisynthetase syndrome, like PL7 and PL12. The other thing it could be is ribosomal P. Remember, we said ribosomal P is the one that indicates neuropsychiatric SLE. All right, so did mention that it can be quite difficult to distinguish between an AC19 and an AC21, the one that was on the previous slide. It doesn't look like it because this is one that's quite smooth, but sometimes it has a coarser kind of character about it. All right, so we can do a few of we'll do double-stranded SSA, JO1 and ribosomal P. If none of those comes up, then we'll suggest that you correlate with your CK and the aldolase. Sometimes the CK is normal, but the aldolase is elevated with and then with your blood. Okay, the last patterns that we get are your mitotic patterns, and in some labs they ignore them. Okay. But we feel that you can see in terms, if you look at the conditions they're associated with, they are clinically relevant conditions, and there are some of them serious autoimmune conditions. It is true that it will be more likely if the titer is high, then it could be an autoimmune disease. All right, so what we will do for this is this is 24. This one is called centrosome. 25, this is mitotic spindle fibers. 26, that's pneumo. 27 is bridge, intercellular bridge, and then 28 is called mitotic chromosome. Well, you see it also has a positive metaphase plate. So what we will do for this, if we'll say, okay, it's a mitotic pattern that we've identified, we run the ENA screen. If the ENA screen is positive, we'll do an at least a double-stranded DNA and an SSA. Sometimes if you find nothing, you could decide to extend the profile a bit. Okay? The reason you can't just extend it and run all 14 is because it's expensive. All right. Then, so I don't know if this is a slide about the costs. How much does all of this stuff cost? I don't know if someone has got any questions before we get to that. Okay. All right. So an issue first is about the practical aspects of this testing is that the test, it's batched. So that means that it takes quite long for these things to run. So it's not a sort of random access. You're going to quickly load it and then in half an hour there's a result. It doesn't work like that. But in terms of your ANA, it's on this digital microscope. So obviously we have a lot of help with it's doing automated processing and putting the samples onto the slide and so on. But it takes at least 3 hours for us to have this, have all the images. Then we still have to read the images. So we sit and we look at the images, get rid of the negative ones, we sign up, then on the positive ones, we look very carefully. Remember your pattern of your ENA. So if your ENA screen is raised, you're going to do your breakdown according to the pattern you see. So you need to have the pattern before you can do the breakdown. Okay. And then for certain samples, you would want to do further titers. Okay. So now we don't wait until tomorrow because now you've done your batch for the day, it's finished. So anything that needs to be titered will go onto tomorrow's list. But we do, preliminary, you can see, okay, I think it's a speckle and a cytoplasmic. So we can already add, if your ENA screen was positive, we can add the breakdown so long. Okay. Otherwise, you would have to wait 2 days before you get any results. Okay. The other problem as well is that your folio, so this is the one that you do the ENA screen and the ENA breakdowns on. It also takes very long. You can see running your QC and stuff in the way that takes 2 hours, and then to do the sample run and 2 hours. So just to say that this isn't really something that can be done stacked. It's going to take 4 hours at least. All right. And then in terms of the pricing, so there are 3 codes that are used in autoimmune testing. So the 13934, this is for your indirect immunofluorescence. Okay. This is the sort of range. Mostly it's about 300 Rand. That's the average. So that's for your screen, 300 Rand. And then for everyone, double-stranded SSA, SSB, Smith, or in PD1, ribosomal P, 300 Rand each. So it's quite a bit. And then in terms of, sorry, that was I was talking about the ENA. The ANA is the one that's 300 Rand. The ENA is about 250. Okay. All right. The ANA is about 300. So if we manage to see the pattern properly with one, that's 300 Rand. If we need to do further titers, it's going to be more. So especially for your very high, strong ones, sometimes you need to titer 4 additional. So you can see how the costs are escalating. All right. And then in terms of your blots, that's the kind of range for the blots. The highest tariff is for the cash price. But luckily for cash, you do get a discount if you pay within a discount, and you get a discount for senior citizens. But this is more or less what's about 1,500 average, like for discovery or something. So you can see these things can get quite expensive. So we try and look at ways in which to, for example, make our breakdown panels not so extensive. So quite often I draw stats to see in the last 6 months for a certain pattern, when we had a positive ENA, what were the antigens that came up? Because you can't be doing. Okay, and that's just the
Thank you so much. I think I like the idea of 4 hours. So can we do 4 hours and a half for my results? If that agree, we can start working.
But let me understand, the sample has to come into the lab. So the pending list is drawn. The sample has to arrive. It will be done,
That's 10
processed
minutes.
the next day.
10 minutes.
So the processing is the next day.
Yes, so what happens is they will draw it in the morning.
Yeah.
Okay, so we'll load all the samples. So so that's early in the morning, like 7 o'clock, we've already loaded. So if your sample comes in at 10, it won't be ready at 2. It will only go onto the
Tell me
instrument.
about your batch. How many does it fit in? Maybe that's where we start.
We do about 50 a day.
So if you don't get another 50,
No,
We do it anyway.
we
No,
do-
So just looking at the volumes and the costing and the rest, if the volumes would be increased, one might want to look at 2 batches a day.
okay, so far, that's what we need to do. Put more 2, 3, 4 batches and make sure that within 24 hours to get our results, obviously.
Yeah, look, we are looking at doing shifts. Okay, so we just our lady that was in charge of the section retired, so we got somebody new. So now we just have to look at doing maybe 2 shifts a day. Then you could
So
increase
these progress, yes.
Yes.
Yeah, I think that process for reputation, yeah.
So my question is about testing and retesting. We get a lot of referrals from GPs where the ANA is positive, for instance, 160, and then they repeat the test, and now it's 80 or going. So, what is the?
They actually say that you're not really supposed to do it. You're not supposed to repeat ANA testing over and over, unless, it's a patient, let's say, that has they've got a diagnosis and now something's changing, or they've developed new symptoms, or there's something like that. If you want to see, what's going on now, there's a new pattern. But a lot of these ones, like the ones from GP, so it's now, it's a AC4 pattern, it's a 1 in 160, the ENA screen is negative. It's very likely that it's not something.
Yeah.
And we actually do see, because obviously we do find repeat testing happen. So we'll see sometimes years later the same pattern. And the titers maybe can go up and down. The titers it's not an exact science because it's an observer,
It's not an indication of disease or the severity of disease, because I think that's the issue that we get.
Because
So
the titer is very high,
Yeah.
if it's from 640 and up, then you're sort of a bit worried about this.
Yeah.
But you must keep in mind, remember, if it's an AC2, even if it's a high titer, it could be nothing. It's more likely that it's nothing, especially if your DFA 70 is raised.
I have some observations when I've seen patients, like some of the older patients, they've got hematological malignancy and they've got other kind of symptoms, it's not adding up. And based on the disease, we do an autoimmune screen. So an ANA comes back as 1 in 80 or something like that. And it's an elderly patient, and that's one of the reasons why they could be. I've repeated it and it's negative. Why is it with the elderly population that you get that kind of?
Well, I guess it's just the, autoimmune dysregulation happening. So it is true that you do find it higher in women, more ANAs positive, and elderly people with malignancy, all of this type of thing. There's an immune dysregulation. So you can find positive ANAs that are due to non-autoimmune disease.
Just another 2 questions. One, of course, to do in pulmonology, we have what we call idiopathic pulmonary fibrosis with autoimmune features. And that means somebody who does not meet the criteria of autoimmune disease, but they have a fibrotic lung disease. And by definitions, when you say autoimmune, we look at, obviously, there's quite a good, clear definition. We look at the ANA. If it's, let's say, it's a nuclear pattern, we look at the titers of 1 to 250. If it's, of course, if the pattern is more centromere, it's more specific, it means tells it it's an underlying autoimmune disease. And obviously, if the pattern is like, let's say, it's ribosomal, then you obviously do it according, but they don't meet the criteria. That's one. The second thing is, of course, that we have a group of class of fibrotic lung disease like IPF or drug-induced whatever, But because the condition has been so long, for those patients, they will have kind of positive rheumatoid factor. They might have positive ANA, but that does not signify that's underlying disease because the titer is extremely too low, and obviously depending on the pattern. That's one of the issues that we have. The question that those patients normally we need to repeat their autoimmune markers within 6 months because sometimes the fibrotic lung disease can precede the onset of autoimmune disease manifestation. So there's always a role to do that. So it's always very important as a lab that there's actually kind of looking at the pattern throughout. And obviously, once if somebody got a titer 1 to 80, and then 6 months down goes to just 125 or something, that means probably underlying autoimmune disease. And then perhaps you need to do more complete panels. So in respiratory, we would like to have more detailed panel investigation of autoimmune disease if someone got an autoimmune fibrotic lung disease. The reasons two. One is influence the mode of the therapy. Obviously, if they got autoimmune disease and the fibrotic lung disease, those patients are not candidate for antifibrotic, but they're more positive for immunotherapy like rituximab or your Salsep or cyclophosphamide or something like depending on the sort of cellularity of the fibrosis. And then that's how we always do that. So we always need more detailed autoimmune assessment on those aspects of those with lung problems. And then you have two groups of people that, of course, that I think elder malignancy. We've seen quite a lot of cases with Dr. Van Rooyen where they come actually, they're having feature of autoimmune disease, but once you really go into details, they don't meet any particular criteria. And we have in particular one elderly woman that actually got fibrotic lung disease and their NA were positive. However, we were just concerned, and then I remember then say post-COVID, is it whatever stories, but anyway, we decided we applied for rituximab. 6 months away, they're supposed to come for rituximab, we find out they have a lymph node. When you biopsy, one got squamous carcinoma, one got lymphoma. So obviously you do get it. So I think maybe from age of 65 above, I always say that from age of 60, anyone with autoimmune disease probably need to wait and look for underlying autoimmune disease because autoimmune disease probably are more useful diagnosed during early years, like from 20s up to 40, 45. But from 65, you have to take the titers with a salt. And the question that can we repeat those titers within 6 weeks to make it accurate diagnosis? Because giving those people rituximab might be a death sentence for them. What's your opinion on those? Just comment or whatever.
Yeah, I feel obviously if there are clinical indications for some, because obviously your many of these things, your ANA and that, they actually might start increasing months to years before the autoimmune disease it will manifest.
Or after.
Eventually, yeah. It's not, so, I mean, obviously we like to feel that many patients, hopefully it's nothing, but in some patients it is something. So I would like to, that's why we like to see the results, because you can kind of, the values. I know some people are used to seeing negative and positive, but for me, I like to actually see the values so that I can see, what is this antibody actually? Oh, I know that you can't use it for monitoring and you're not supposed to. The only one that you're supposed to really use is double stranded DNA. But for us, when we look at the results in the cumulative report, it's quite helpful to see, okay, this thing is increasing or it's decreasing, or it's, especially if it was something that was kind of equivocal. And now 6 months later, when you do it, it's moving into the positive range. It seems that there is something.
And then finally, just comment, would you guys be, we happy with certain kind of results that you guys like, let's say hyponatremia, if we have it, always have a diagram in the back, which actually become like AI for physician, who can follow the pattern, how to reach diagnosis. Would you guys be attaching that also into your ANA if it's positive and given the physician said, listen, it's AN positive, these are possibilities for you to do that? Based on what you present?
Yes, we do that. So our report does include the SLE criteria. If I report on a mixed connective tissue disease, then I usually I paste the diagnostic criteria. I'm not sure which ones you are using, but just for a guide, if you have a look, and I've got ones for systemic sclerosis, and I've got ones for autoimmune hepatitis, and ones for PBC. So I do paste some diagnostic criteria that you can look at to bite you a little bit when you've seen the results.
Thank you so much. Otherwise, this video presentation, we appreciate it. Yes, anybody online? Sanet is already standing up. They want to hear you guys. Hello?
Yeah, good morning all. Great presentation. No questions from my side. Yeah.
Thanks, Dr.
Thank
Colley.
you.
The fellows, the Kempa team, those on the backyard. Yeah, close.
If there's no questions, we'll say goodbye.
Thank you. Thank you for sharing. That's